Good afternoon, good evening, everybody from all around the world who have joined us today on this Christmas Day to have our ACNS WIN webinar, which we are planning to hold now more frequently so that we can all enjoy the discussions. So I will be chairing the session today. Dr. Sharon was unable to join today. She had a flight. So before we start the session, I would like to invite Professor Kato for a welcome note.
Okay, thank you very much, Avilasha. So thank you so much for everyone. So today we have a very nice 6 lectures. So the very variety of the topics, maybe we can learn a lot from them, I think. So maybe Sharon, we can start. Sorry, Abida, we can start.
So I would like to invite our first speaker, Professor Fukuda, who is going to be talking on high flow bypass. You may please start, Professor.
Okay, thank you. I'll share my presentation. Just hold on a minute. Okay. Do you see my presentation?
Yes.
Okay, yes.
So thank you, Chairman. Today I'm going to talk about surgical nuances of high flow bypass and interposition radial artery graft. I'm Dr. Hitoshi Fukuda from Kochi, Japan. I'm not sure if my presentation can be the Christmas present for you, but just let's get started. And today I have 2 topics, fundamental technique of high flow bypass, and then application of radial artery interposition graft to other pathology. I'm going to start with indication of high flow bypass for therapeutic ICA occlusion. First of all, we always consider the flow diverter as a first choice for intractable ICA region. However, if it is less effective or risky, we choose therapeutic ICA occlusion. And when sacrificing ICA, we take the universal high flow bypass. So we always think about using the high flow bypass. However, if the systemic tolerance of the patient doesn't allow such an invasive surgery, this may be replaced by balloon occlusion test with or without low flow bypass. So ultimately, we mostly use this high flow bypass strategy for subarachnoid hemorrhage, acute subarachnoid hemorrhage case, dissecting aneurysm, and traumatic or infectious injury of an internal carotid artery. Here, I will show you the procedural steps of high flow bypass. There are 6 steps, but today I'm going to focus on this 235 STA-MCA insurance bypass, subcutaneous tunnel for graft route, and external carotid to radial artery graft bypass. First, I will show you STA-MCA insurance bypass. Insurance bypass may be unfamiliar to somebody, but this bypass is STA to distal MCA bypass before the radial artery bypass. While the radial artery graft is anastomosed with M2 portion of the MCA, we are clamping the M2 for 20 or 30 minutes. So during this clamping time, this STA M3 bypass secure the blood flow of the distal MCA territory to prevent ischemic complications. In addition, later in the surgery, this insurance bypass also works as a monitoring of perfusion pressure of the MCA to check the function of radial artery graft. When we complete the radial artery graft bypass, it is temporarily clipped, and then this parietal branch of the of the STA is cannulated to connect the arterial pressure transducer. So now we have two transducer pressure. One is for systemic blood pressure, and one is for STA pressure. And then first, when we clamp this STA frontal branch, the transducer shows the STA pressure. So we can check this transducer is working. And then the main trunk is STA is clamped. So now we know the MCA pressure when ICA is open and graft is closed. Then we clamp the origin of the ICA. So now we know the MCA pressure when ICA is closed. So that this transducer pressure radically goes down. And finally, we declamp the radial artery graft. So this transducer shows the high flow bypass pressure when ICA is closed, so that we can now know whether the radial artery graft is functioning. Next, I'll move to subcutaneous tunnel for graft route. Basically, this graft going submandibular and subzygomatic route from cervical to cranial portion. At the cervical portion, this graft goes above the digastric muscle, and then at the cranial portion, this graft goes between temporal muscle and radial pterygoid muscle. And actually, when we are making the graft route, we always use the index finger of one hand and �𝑗𝑟𝑖 forceps in the other hand. First, as the cervical portion, we insert our index finger to touch the steroid process and move the index finger a little anteriorly to wait for the �𝑗𝑟𝑖 forceps coming from the cranial part. And then we insert the �𝑗𝑟𝑖 forceps from the anterior half of the subzygomatic space to the under the temporal muscle along the temporal bone into the infratemporal fossa. As the infratemporal fossa, the �𝑗𝑟𝑖 forceps is rotated posteriorly to touch the index finger. And then finally, this tip of the forceps are guided into the cervical portion by the index finger. Next, I'll show you the step of external carotid to radial artery graft bypass. In this step, we have to focus on avoiding redundancy of the graft and keep the graft straight. One of the reasons is that after the surgery, we get back the patient neck from the rotated position to the supine position. So if the graft is redundant at the surgery, this bypass will be more redundant and kink to lead the graft occlusion. To do this, first we prepare the proximal end of the radial artery like that, 1 to 2 ratio to make this opening. That way, the graft is going parallel to the external carotid artery. And then, when clamping the ECA, first we insert the proximal bulldog forceps parallel to ECA, and then pull and anchor the graft to make this graft straight. And then we twist the distal bulldog forceps anteriorly to make a nice space for this straight graft. This is a video of left high flow bypass. This video doesn't work. I don't know why. Okay. This is a STA frontal branch and parietal branch. They are dissected. And then left front temporal craniotomy is made. In the Sylvian fissure, the M2 portion of the MCA is exposed like this. And this is M4, a superficial MCA. STM4 bypass is made and bypass is okay. The graft root is made, as I mentioned earlier, like this. And then distal end of the radial artery graft is stitched to the M2 portion with interrupted suture of 8-0 nylon. This is the cervical portion. I prepare the proximal end of the graft like this to make the graft go straight. Make a big fish mouth shape. And then the proximal bulldog forceps are inserted parallel to the ECA, and this is a distal forceps, which is rotated anteriorly to make a nice bypass space for straight graft. After clamping, the arteriotomy is made by vessel punch. And then radial artery graft is anastomosed with running suture of 6-0 prolene at this side and the other side. Now bypass is okay, like this. And then the parietal branch of the STA is cannulated for intraoperative monitoring of the blood pressure. ICA is clamped. And now ICG video angiography shows bypass is okay at the cranial portion and the cervical portion. Next, I'll show you several options of therapeutic ICA occlusion after high flow bypass. This is a case of extracranial proximal ligation. When the region is located extracranially, proximal to the ophthalmic artery, we can just ligate the proximal ICA to cure this region. This is a case of infectious aneurysm associated with abnormal narrowing of the ICA. In this case, flow diverter is risky. So after the high flow bypass, we just ligate the cervical ICA and that's it. Next, I will show you the case of trapping with 2 clips. When the region is located proximal to PCOM and distal to ophthalmic artery in the intracranial space, we can use 2 clips to trap this aneurysm. This is a case of subarachnoid hemorrhage due to blister-like aneurysm of the C2 portion of the ICA. So we used 2 clips to completely trap this aneurysm. We also use the trapping with coils. When the region is proximal to PCOM but involving ophthalmic artery, This is a case of subarachnoid hemorrhage caused by giant ophthalmic aneurysm. In this case, distal clipping is very difficult. So in this case, we initially start with anchoring coils placed in the intraluminal lumen of this giant aneurysm, and then subsequent coils are occluding the ICA to block the blood flow. However, sometimes we have to take this distal clip and coil strategy for complex aneurysm. The location of the aneurysm is the same, proximal to PCOM, but involving ophthalmic artery. However, this is a subarachnoid hemorrhage case caused by dissection of carotid siphon to C2 portion, portion of the aneurysm. In this case, starting coiling in the fragile or shield lumen is very risky, and starting the coiling from the intact internal carotid artery may cause the migration of the coils to the orifice of the PCOM. So in such a case, we have to take this strategy, which is a combination of distal clip and coils. After high-flow bypass is set, in the carotid cistern, we put the clip on the ICA just proximal to the PCOM, and then coil embolization is done by using this clip as an anchor, so it is not so challenging. The surgery is successful. Post-operative imaging shows both clip and coils. High-flow bypass is okay, and the PCOM is still patent as a flow-out of the high-flow bypass. Finally, I'll show you the intracranial proximal occlusion case. It is used when the lesion is involving the anterior choroidal and posterior communicating artery. This is a case of giant C1, C2 unruptured aneurysm, which was treated with flow diverter when this is the aneurysm size was 32 millimeter. However, 1 year later, this aneurysm got bigger to cause the symptomatic epilepsy and hydrocephalus. The coiled aneurysm is located just across to the PCOM and anterior choroidal artery. In such a case, we cannot sacrifice the PCOM and anterior choroidal artery. So by using the combination of open cell stent and coils, we only occluded the proximal portion of the ICA. After the operation, the blood flow to the aneurysm disappeared. Next, I will show you application of radial artery interposition graft to other pathology. Sometimes we have to use a high-flow bypass to reconstruct the whole basilar artery system. This is a case of left side giant thrombosed vertebral artery aneurysm compressing medulla oblongata. Now you can see the contralateral vertebral artery is tiny. This aneurysm is mostly composed with intraluminal thrombus, so we have to clip the parent artery. First, we perform the combined transpetrosal approach to expose P2 portion of the posterior cerebral artery. This is an intraoperative view. This is a radial semicircular canal, and now I'm drilling Petrus reach. After the P2 portion is secured, radial artery graft is anastomosed with P2 portion, and the proximal end to V3 extracranial vertebral artery. After the bypass is completed, the vertebral artery proximal vertebral artery is clipped. So this is a final view of V3 RA P2 bypass together with proximal clipping. Radial artery interposition graft can be also used for bilateral ACA reconstruction. This is a case of neck clipping of large thrombosed ACOM aneurysm under bilateral ACA bypass reconstruction. This is an unruptured 22 millimeter aneurysm, but most of the aneurysmal lumen was filled with thrombus like this. So in order to clip this aneurysm nicely, we have to remove the entire thrombus before clipping. So to secure the entire ACA territory while we are removing the thrombus, I used this STA-RA ACA bypass combined with A3 side-to-side anastomosis. So we made 2 bypasses. This is the operative video. First, we expose the left side main trunk of the STA and by frontal craniotomy. This is the A3 portion of ACA, bilateral ACA, and side-to-side anastomosis is made. After that, ACA branch and radial artery bypass is made. And this is radial artery to STA main trunk bypass. This is a thrombosed aneurysm. And we clamp all the surrounding A1 and A2. And then the thrombus is removed and clipped. The aneurysm is clipped. Radial artery interposition graft can be also used for revascularization of common carotid artery occlusion. This is a case of right minor stroke caused by right CCA occlusion. Because the patient didn't have a open cervical carotid bifurcation, but has a large STA extending contralaterally, we bypassed this. We bypassed from the STA frontal branch to contralateral M2 bypass. This is also called bonnet bypass. Another case is also the right side minor stroke caused by CCA occlusion. However, because he has an open cervical carotid bifurcation supplied from the occipital artery, we made this skip bypass from side cervical trunk to common carotid artery. In summary, making graft route and setting of ECA bypass are specific and critical steps of the high flow bypass. Donor, recipient, and graft length must be carefully considered when using interposition radial artery graft. Thank you for your attention.
Thank you, Professor Fukuda. That was a wonderful lecture. That was a wonderful lecture with a lot of technical nuances of performing bypass surgery. And I'm sure it will be very useful to all our viewers around the world. And you showed very good techniques of using hybrid methods of treating aneurysms, combining both endovascular and surgical methods. And, that is how it should be, tailor-made treatment for aneurysms. So thank you very much. I'd like to invite our discussions. Dr. Sukirti. Unmute.
Yeah. Sir, your surgery sound very, very technical. My simple question is that how much time did you spend in each of the anastomosis, and was it really, did you do any long-time training, because you are straining your eyes continuously maybe for 5 to 6 hours? Did it take a toll? Was it one surgeon or was it 2 surgeon surgery?
You mean the whole entire hours of the high flow bypass?
Yes, yes.
Basically, it takes 7 to 8 hours, and actually three surgeons are working for the high flow bypass, but actually we start with cranial part and the cervical part at the same time, or the cranial, and maybe the one surgeons are doing the cranial part, and during that time, the second guy is taking the radiographic graft and then the cervical dissection. So that these procedures are finishing almost at the same time.
Okay, so it's more of teamwork. You are coordinating with the timing.
Teamwork is very important. And then sometimes the residents are doing the STMCA bypass. It is straightforward. And then a well-trained doctor is doing the M2 bypass and cervical bypass. So it is very good to share the difficult part and the easy part for the. It's like a flexible to the.
So basically, you're saying as youngsters, first we have to master the STA-MCA, then progress.
That's true. STA-MCA is a basic procedure for the older vascular neurosurgeons, especially at least in Japan.
Thanks.
Dr. Lim, are you there? Hi, Dr. Lim.
Hello. I just like to commend also Professor Fukuda for that very extensive discussion. Thank you so much, Professor. I just like to ask, when you remove the thrombus from all these other aneurysms, do you supplement it later on? Because if you're going to do a bypass, then how can you prevent further occlusion of these bypasses later on after your procedure? Do you have any medical things that you do to preserve your bypass?
Basically, I don't use any anti-coagulation or anti-platelet for this kind of bypass. However, when patient has some kind of specific pathology, like the parent artery dissection or something like that, and then if we have to manipulate the dissection part or very close to the dissection part, sometimes we put some anti-platelet to the patient from the nasal tube, because we don't have an IV antiplatelet. I don't prefer the anticoagulation to this kind of bypass. I only use the heparin to the endarterectomy.
Thank you so much.
Thank you, Dr. Lin. Does any young neurosurgeon have any question for Professor Fukuda? Professor Kato, would you like to make some comment?
Thank you very much, Professor Sensei. So it was wonderful talk and very extensive for the skill. So maybe you have so many maybe tips. Maybe you don't have enough time to tell us about succeed of the high flow bypass, I think. So do you want to say some complication of the high flow bypass? Maybe just one or two, please.
Actually, like the other bypasses, like high flow bypasses, like very it doesn't have a lot of options. The procedures is very straightforward, like the order of the patient, STMCA bypass and high flow bypass. So sometimes the complications happen because of the patient factor. So my complication happens when the patient had severe atherosclerosis as the cervical portion or the cranial M2 part. So in such a case, we have to choose the part of the less atherosclerotic part, or sometimes the external carotid arteries has a very, very severe atherosclerosis. So in such a case, we have to change the bypass place to the common carotid. So such kind of troubleshooting is very important. However, sometimes we cannot avoid such kind of complications because of the patient factor and mainly by atherosclerosis.
Thanks a lot. Thank you very much. So congratulations.
Thank you. Thank you, Professor Kato. Thank you, Professor Fukuda. Let's move on to the next presentation. I would like to now invite Professor Hayashi from Tokyo for his lecture on knack and pitfalls for microsurgical dissection of Sylvian fissure and interhemispheric fissure.
Hello, everyone. This is Dr. Yoshifumi Hayashi. Yes, Professor Yoko Kato, thank you very much to have this opportunity today. So my topic is about the knack and pitfall for microsurgical dissection of Sylvian fissure and interhemispheric fissure. Let me share my slide now. Wait a moment, sorry. Yeah. Can you see my slide? Okay.
Yes.
Okay.
Go ahead.
Thank you. Let me explain my career. I started my career at Kameda Medical Center in Chiba Prefecture in Japan. Since 2005, after I graduated. At that time, Professor Hadeishi is my first mentor to do this kind of microsurgery. And he's also famous in Japan to do a very precise operation in the microscopic. So my topic today is based on his teaching to me. Also, I work now in Kitahara International Hospital, but since 2015, I work in Cambodia as an educator of neurosurgeon, as well as general internal medicine there to provide a good practice for the Cambodian patients. So today's topic is very basic point of view from the senior neurosurgeon, but maybe I hope to have some good impact for the young neurosurgeon today. So wait a moment here. So about how to separate the fissure gently is very important. It's a very first point to lead to an aneurysm or tumor. But I know that in country to country, a kind of some practice is different. So today I share my topic, which is common concept in Japan. So to open the fissure gently, we have to understand arachnoid very well, because if we understand arachnoid and if we don't damage the pier, you can reach the goal to the aneurysm or tumors. First, let me explain about the Trans-Sylvian approach. For Trans-Sylvian approach, first point is to open the surface of arachnoid membrane and manage Sylvian veins. So, like this figure A, arachnoid membrane have the surface layer and the deeper area, which are overlapping superficial Sylvian veins. Then, below this area, there is arachnoid trabecula. Then we lead to the M2. Then, if we go proximal to the M2, we lead to the M1 IC, and then we can separate Sylvian fissure correctly. So first, we should consider which area of arachnoid membrane should we cut first. So I mean the lateral area, I mean the left side from the operative view, left side, middle, or right side, we should consider very carefully. So like the image is B, if we can see two branches of vein, which are very common type, it's very basically easy that if we choose the middle area, maybe the left side is belonging to the left lobe, which is frontal lobe in this picture, and the right side vein belong to the right side row, basically. So you can start the middle area if you can. But it depends on the situation. You can choose another point, and then you can change the opening area if some vein is interrupting your vision. For example, this nice illustration is also coming from the same article. For example, this picture A, sometimes if we go deep area, we may notice some bridging vein between right and left. It is relatively common. In that case, if we continue to insist to open this angle, maybe some bridging vein intervene your progression. So in that case, like picture B, you should move the main vein and you should change the angle of your operative view, like this arrow B. Then, of course, you can go from the A area, but also you can go to the B area. You can change the microscopic position and you can reach more. You can make a wide view. So first step, you should consider to go which area of vein, Sylvian vein, is better to reach to the target area. It's the important point. And this is what I perform usually to open the Sylvian fissure first. First, I use the 27 needle to cut the arachnoid membrane on the surface. I know some institutions may have micro knife to cut here, but like my institution, if you don't have some knife, you can use the 27 needles to just cut the initial point. Then you will move the microforceps bilaterally. Both hands you should have microforceps and just tear off the membrane gently. This is very easy to open the first arachnoid membrane without any damage of the pier or vein. So I recommend to do this procedure. So here is some example of subarachnoid hemorrhage, right MCA ruptured aneurysm. I share some video. So this case, we see two branches of Sylvian vein, but I choose left side, which means a frontal lobe side first, because we can see some space here to open easily. So I use the needle, just make a hole here. Then I use the microforceps to tear like this. So you may see you don't have some risk to damage the vein or pier by this procedure. So you should open as much as possible. Then left hand, you use a suction, make a counter pressure, and cut like this way. Okay, next topic is about the concept of each dissection techniques. So I explain blunt dissection, sharp dissection, counter pressure. About blunt dissection, which means the splitting the adhesive tissue by using forceps, bipolar, or dissectors. Sometimes you can use scissors even to do blunt dissection. If you put the scissors inside of the tissues in closing way, then open the scissors, then you can do the blunt dissection also. So this can tear the tissue. So if arachnoid trabecula are weak, it is easily to separate without any damage. But this makes some pressure at the surrounding tissue. So if the pier is already damaged or some weak point like a hematoma, it's not good way. So you should use blunt dissection and sharp dissection together. So case by case, you should change which way is better to the brain. So please consider like this. And one more thing, in a SAH case, already usually there is a hematoma in the arachnoid fissure, I mean the Sylvian fissure area. So hematoma already opened the fissure in some portion. So just wash this hematoma and do some kind of blunt dissection using bipolar may separate easily. So compared to the unruptured aneurysm or tumor cases, hematoma cases is more easily to use blunt dissection. That's my opinion. Oh, this is actually the interhemispheric approach that I want to share the hematoma cases. So interhemispheric cases are similar, just gently make a counter pressure and use sharp dissection by cutting. But if you found the hematoma, just gently suction the hematoma and then like using like this way, not only cutting, but also retracting together and make a blunt dissection can separate the fissure easily. This is a sharp dissection, actually. So you need to do combination. I did the blunt dissection this way. Okay, let me skip this video. So sharp dissection, as you know, we use scissors. So it doesn't damage any peer. So it's very good way to do sharp dissection. So please try to make a good view to do sharp dissection. Then, so the combination is very important. Let me share the unruptured case, left ICPC aneurysm. So I again use needles to cut, then use microforceps to open. So this is a blunt dissection using scissors. So I don't cut only, just bring the vein or arteries like this. Microforceps also good to use for a blunt dissection. So maybe we already did the IC aneurysm. There is an aneurysm, and also we can see the oculomotor nerve behind the aneurysm. So we gently retract, we make checking the PCOM area, 𝑗 artery. I use some dissector to move the aneurysm like this. Then some neck clipping performed. Okay, let me skip. One more important thing is the counter pressure. So to make a tension at the arachnoid membrane or trabecula to be cut is very important. So we can use brain spatulas or suction tube to make a cutting point and do the sharp dissections. So this counter pressure sometimes damages the brain. So have to be very careful, very gentle way to retract the brain. This is a very old textbook, but very informative. The Professor Ito make this wonderful view that first we use retractor. The first step is a very shallow angle, then gradually go to the deep area. It's very important to protect the brain. So please understand this movement. Then let me share several knacks for separating the fissure. This is already published in World Neurosurgery 2015 by Dr. Hdesi, and the first author is Dr. Maekawa, former co-worker. First concept is a paper knife technique, which means that when we use a paper knife, we insert the knife deeply first, then cut up the paper at the surface area. So like this way, please go into the deep area first at the near side. Then you can put the suction tube to make a counter pressure. So using this way, the proximal part become a shallow area like this. Then you can easily cut this area for like scissors. I mean, the sharp dissection is becoming easier. So not only the Sylvian fissure, but also interhemispheric fissure, it's very important to consider this kind of paper knife technique. Another thing is a so-called denude technique, which means undress the Sylvian vein. Like these pictures, sometimes the breaching vein is interfering your vision. At that time, you just undress this arachnoid membrane from the breaching vein and cut there. Then this vein can move more. Of course, hard retracting may damage the vein, but you can make 1 or 2 millimeter more retraction by this technique. Another thing is a so-called microvascular Sylvian fissure, which means to consider or to mind the affiliation of each vascular pair. I already explained a little bit, but during the operation like this picture, sometimes we try to separate the left and right, but some artery or vein is bridging. We don't know at this point, this artery is coming from left side or right side. But after we open carefully, we may understand this bridging artery belongs to the left side. I put the blue color here. Then, of course, at that time, we can separate the correct area. So not only artery or vein, but also pair also may have some affiliation or belongings. So you should consider every time which lobe is belonging to. Very important. Let me share this video. This is the last month's cases with juniors. And this is I think it's sorry, it's a left side MCA aneurysm case. But what I want to share is that during separating the lobe, actually here, can you see? Let me do again. During separating this area, yeah, the right lobe's pair is moved to the left side and damaged. So the retraction is too strong. You can see again here. This is all pair is tearing off. So it's not a good way, but the operator didn't notice this one. Then this operator continued to cut this wrong direction. So the right side pair damaged a lot. Then like this way. So this artery is connecting together. At that time, we don't know this artery which lobe is coming, but we carefully check proximal and distal, and then finally we understand this is a left side one, and cut here and separate and go to the right area to separate. So again, please consider carefully. Finally, just mention a little bit about the interhemispheric fissure. The procedure concept is the same. Try not to damage the brain. But in general, the pia matter is connecting together tightly compared to the Sylvian fissure. So more technically careful is important. You need to control scissors and suction carefully because it's also a very deep and small area. So also moving the microscope a lot is important. Change the angle and position to separate in the easier way. So please consider this one. So in conclusion, I share some basic concept to separate the fissure in shape in Japan. So making a good view is very important, and considering to use either sharp dissection or blunt dissection with moderate counter pressure. One more slide again. So about 7 years ago, Professor Yoko Kato came to Cambodia and organized a very wonderful convention in Cambodia, and every young Cambodian doctor remembered well of this episode. So please come again. Thank you so much.
Thank you, Professor Hayashi. That was a great lecture and some very good tips to separate the Sylvian fissure. As we all know, opening the Sylvian fissure is the key to aneurysm surgery. And if you have the right technique, the whole frontal and temporal lobes will fall apart and open like a book. And then you can enter all the carotid cisterns, the basal cisterns, and it gives you a fantastic view of the entire circle of Willis. So, Dr. Anila, you have a question?
Hello, fantastic lecture. I really enjoyed it. And I just have a comment and I have a question. My comment is that this was a wonderful lecture in that way that very few people actually teach you these detailed nuances in dissection of Sylvian fissure, and you have just done it very beautifully. I also use the same technique of using two jewel forceps to dissect the arachnoid while tumor resection. So thank you for that. My question is that sometimes, no matter how hard you try, sometimes you have to take a vein, right? Or the vein ruptures during the surgical procedure. Do you have, and the brain swelling then happens, especially with tumors and things like that. So do you have any tips or techniques that if something like that happens intraoperatively, and sometimes it even happens postoperatively, how should we deal with it?
Thank you so much. Yeah, of course, not 100% we can complete the opening very well, but sometimes if some problem happen, we try to reach to the aneurysm as soon as possible. So some damage we have to accept. So we do the blunt dissection by using bipolar, then try to reach to the aneurysm as soon as possible and do clipping. Or of course, very swelling a lot. Sometimes we have to do internal suction of the brain to make a operative view. So sometimes it happens.
Thank you so much.
Dr. Sukirti?
I just wanted to appreciate you for your lectures, like superb. One very unique question that is to Japan. Are you using the same suction system that they use in Japan? Because
Cambodia,
the rest of the world uses a different system.
That's right. Yeah, actually, I use the same one compared to Japan. I bought in the company is a Mizuho, the famous company in Japan, and buy some sections over there.
Okay, and by the way, I was also there for the 2016 conference, and you might not remember me. I was a kind of young student that time, and I met Professor Kato, and she encouraged me that time.
Thank you so much.
Dr. Lin, do you have any comments?
Yes, I'd like to thank you, Professor, again. I appreciate very much the illustrations that you did yourself. It was fantastic. And also, I would like to ask, when you're already approaching, for example, an ACOM aneurysm and the gyrus rectus is draping somewhere there, how do you proceed? What are your tips for that? Do you take it out directly, or do you go around it?
Thank you so much. Usually, I prefer to do the similar procedure in each cases. So try to open widely, like in the hemispheric fissure. Usually, I do the same way, the open very widely, and then lead to the aneurysm or tumors. The Sylvian fissure is the same, usually the same way, the distal Sylvian approach to open very carefully. Then the young neurosurgeon also can practice if they perform the similar way. So that's my understanding or my philosophy to do this.
Thank you so much. And also, you go directly down to the bridging veins of at the base. Do you take it out already so that it will not hamper your vision and you are able to open it up better?
Yeah, so usually we try to preserve the vein. So if some vein is interrupting, we don't coagulate much. So we try to open the other position and try to preserve the vein as much as possible. Of course, sometimes we sacrifice that, but try to preserve.
Thank you.
Dr. Kubolo, you had a question?
Thank you so much, Professor Bidasha. Good morning, good evening, everyone. I'm sorry, I just joined. I didn't follow the presentation. Maybe the next one I'll ask. Thank you.
Okay.
Thank you.
Professor Kato?
Yes, Hayashi Sensei, thank you very much. Already, he's very much expert, and he taken care for many years in Cambodia Neurosurgical Institute. I admire him. Thanks so much. The excellent lecture. And maybe the once you encounter the premature rupture, blood pressure maybe goes down, and also the temporary creep, the proximal site. Also, the recently, if possible, maybe adenosine is one of the way to use such kind of drug. So maybe a most frequent situation, premature rupture is maybe we touch the rupture point, or sometimes some pressure of such a part. So never ever touch such a point. That is most important. Thanks so much. The excellent lecture, Sensei. All the best.
Thank you so
There
much.
is a question on the panel for Dr. Hayashi. It is by Dr. Rakib. He is a fellow right now in Fujita with me. He has asked that which instruments do you use to start the arachnoid dissection? I mean, do you use only micro scissors or only the insulin syringe or micro dissectors? Because some surgeons even use number 11 blade. So what is your protocol?
Yeah, thank you so much. So as my presentation, so I use insulin syringe first, then use microforceps to tear off the membrane, then go to the deep way by using micro scissors.
Okay, I hope, Dr. Rakib, your question is answered. Thank you.
Yes, thank you. I think we should keep the time and we move on to the next presentation. I would like to invite Professor Mao Yakota for a talk on combined exoscopic transcranial and endoscopic and endonasal approach to craniopharyngiomas.
Thank you for Chairman. I am Mao Yokota from Aichi Medical University, Nagoya, Japan. And today's my topic is combined exoscopic and endoscopic approach for craniopharyngioma. 3 cases report. Craniopharyngioma always have a complex shape, extend to suprasellar and hypothalamus. There are adhesions to surrounding nerves and blood vessels. If you leave a tumor piece, it often recurs in high rate, and reoperation is much more difficult than the first surgery. So it's important to aim for total removal at the first surgery. But sometimes it extends anterior or laterally beyond the IC. It's difficult to remove its safety by endonasal approach alone. But through a transcranial approach, it's difficult to observe the stalk below the chiasm, the origin of the tumor. So for the complex multilobular craniopharyngiomas, it's difficult to remove them all from in one corridor. So to resolve this problem, combined transcranial and endonasal approach was developed. But a microscope is big, which occupies the space above the patient's head. The endonasal surgeon is uncomfortable with this situation. So our team developed combined endoscopic transcranial endonasal approach. There is no big mass above the patient, and two surgical teams look at the monitor in front of them and can look at the other team monitor and can talk each other. Of course, two teams can cooperate together in surgery. The recent advent of the exoscope has brought an evolution in neurosurgery. Our department started using exoscope since 2019. Most of the scheduled case for brain tumor is operated by exoscope and endoscope. Here is a picture of combined exoscope and endoscopic approach. We can check each other monitor. This is a schema of the layout of this approach. There are two teams of neurosurgeons and two scrub nurses. So this is case 1, 52 years old male. He has undergone combined interhemispheric and terianal approaches in the past. Tumor recurred with solid component near right optic nerve and cystic component in the third ventricle. Preoperative MRI shows a tumor exit behind the IC terminal, inferior to the right optic tract, is extending to the right side. This case, with endoscopic endonasal approach and exoscopic right frontotemporal craniotomy, was done using previous craniotomy. The adhesions to right optic nerve and brain were very strong. So support from the craniotomy team was important with detachment of the adhesions. The tumor was removed totally. This is case 2, 24 years old male, presented with hypopituitary function and visual disturbance. MRI and CT shows multilobulated suprasellar mass. It extends anterior with calcification. Combining exoscopic supraorbital keyhole approach and endonasal approach was done. The adhesion to the chiasm and optic tract was very strong. Also, the VEP monitoring didn't show any change, but he developed a temporary deterioration of the visual function. But it recovered in 2 months. The tumor was totally removed. This is a post-operation CT. So this is case 3, 37 years old male. He presented with rapid visual disturbance and headache. MRI shows tumor occurred from the left of the back of the base of the stalk and with single giant cyst formation. So, show videos. First, I show you transcranial view. Keyhole group has done eyebrow approach. Craniotomy was 2 centimeters. This is the IC. And this is optic nerve. And tumor adhesion is very strong. Content of the cyst ruptured, and we evacuated this. Medial side of optic nerve, the adhesion was very, very strong. And this is the oculomotor nerve. So this view is transnasal view. And keyhole group peel off tumor carefully. And now we translocated the pituitary gland. This is stalk. And endonasal team removed the tumor under the chiasm. It's dangerous to remove the tumor by endonasal approach alone because it's difficult to observe all the tumor border. It's very effective to use combined approach. This is a basilar. And this is a wet field view. We checked tumor or bleeding. We checked. So finished. The tumor was removed totally. This is a MRI and CT. In all three cases, gross total resection was achieved. In the combined endoscopic endonasal surgery, the advantages are that we can check each other's surgical field through monitors and can exchange each information. As the body of the exoscope is small, we can have enough space above the patient. The patient position is free because the exoscope has a free visual axis. Thank you for listening.
Thank you, Dr. Yokota. That was a very nice technique. Very interesting way of using the exoscope and the endoscope both to remove the tumor. Do you also use the microscope and the endoscope? Or you only use the exoscope and the endoscope?
No, microscope before 2090s we used, but now almost the case is only exoscope and endoscope.
Okay. So very interesting presentation. Dr. Lin, you have some question?
Yes, indeed, Professor Yokota, that was very nice and impressive. Was there an adjustment? You said the use of the exoscope is better because you have a lot of space on top of the patient, right? Migrating or training from microscopic view to make use yourself of the exoscope, is there a lot of adjustment in terms of how you move or how it is easy for the neurosurgeon?
Thank you so much. I become a neurosurgeon at 2019. So my training is start by exoscopic.
Okay.
Yeah, but
So you need not have to adjust anymore.
yes, but my senior change the microscope to exoscope. No different, they said.
Yes, I can see also that is a team approach. Do you also have a team with do you open yourself the transnasal, or do you have ENT surgeons for that, or it's neurosurgeon all the way?
Yeah. What? Sorry?
Do you have like do you cooperate with ENT surgeons to open the nasal part, or it is a neurosurgeon that opens it also?
Yeah, I can do craniotomy team or nasal team. I wanna do.
Yes,
So
because sometimes what I'm
sorry, just I can translate.
Thank you, Professor.
トランススペノイドの時は、耳鼻科が安定までやってくれますかって聞いて。
Yes, sorry, I can't speak English. Yes. 耳鼻科です。
耳鼻科が、yes, ENT team.
ENT team, yes.
Because sometimes we also deal with a lot of, here in the Philippines, we are already doing combining with the ENT surgeon, so that the work that we do transcranial and intracranial through the nose would be limited for the neurosurgeons. So we will preserve sort of the time that we will do it, and also the effort.
Yeah.
Thank you so much.
Dr. Kabulo?
Please, everybody should know that Yokota Sensei, he is one of the experts of the endoscopic and exoscopic surgeon, especially the female neurosurgeon field. Yes. Kabulo?
Yeah, Dr. Kabulo?
Yes, thank you so much, Professor Bidasha. Thank you so much, Dr. Mao, for this beautiful presentation. I think my first question, Professor Lin asked already. I wanted to know if you combine with ENT, so I got the answer. Now, the other question is, what do you think between exoscope and microscope? You said, okay, exoscope is small, you have more space on top of the patient, but in terms of elimination, do you think exoscope is better than microscope? Like when you are not using the endoscope, in terms of seeing the deep structures, do you think elimination is better with endoscope than microscope?
Exoscope advantage. Advantage, yeah. Writing is very good. If scopist, we do some move exoscope. If exoscope, sorry, I can't. If scopist can change.
Can move and change the.
Yes. Right is very enough.
マイクロに比べて光は十分エクソスコープは入りますかって聞いて。
Yes, we use OVI by Olympus. Don't better than not good
illumination.
Yes, yeah, good illumination.
Yes, thank you, Dr. Yokota. Dr. Ben?
Yes, hello, Bidasha, and also hello, I would like to address what Kabulo's question. I think the use, because I also use the exoscope and also comparing to the microscope. I think for the resolution, the highest resolution should be better in microscope. But the degree of the freedom about the illumination, the degree of freedom with the use of the camera head of the exoscope, which we also easier for the surgeon to turn, because the camera, the design is that you can tilt the angle of the camera head so that you can illuminate and see the angle of your field of interest without moving the big microscope when we are doing the traditional microscopic surgery.
Yeah.
But I think the highest resolution should be better in the microscope.
Dr.
Thank
Anila?
you so much, Sabine.
Thank you so much. I think it was very interesting, the combined approach. Definitely, it would be impossible in third world countries to have such a huge team to do 2 surgeries together, but definitely one after another can be easily done. My question is to both Dr. Ben and Dr. Mao, is the brand that you use, I mean, do you have a really fantastic brand of this exoscope that you use that has a good high definition picture so that you can look into all the details?
Yes. Our exoscope is 4K, and picture is very clearly.
And you use like a mount? Do you have like a mount that mounts the exoscope and like a robotic arm or something that kind of moves the exoscope when you want to move your field of view?
No.
No.
No. Yes.
So it's a
So
Anila, it's a very small thing, that it just focuses on the thing. I'm not sure if I've not seen the 𝘠𝑪𝑵, but I've seen the ASCULAP one, and it's quite free to move. I mean, and you can easily move it with joystick actually.
yes,
Okay.
for me, I'm using the 4K cows stores the exoscope. In essence, there is there's two methods that you can adjust the camera. The one is that they could use the hand controller that there is a mounted next to the patients, so that you use the hand to control it. They have another control is by using the foot switch, so that you can control the zoom and also the focus with your foot. So there is advantage and disadvantage of using it. Personally, I think you need to adjust yourself to use it. Sometimes you will find quite difficult, especially when you're not familiar with using your foot during your operation.
Thank you so much.
Professor Kato?
Yeah, but Anila, maybe the exoscope will be very compact, so easy to use, I think, comparing with micro.
Yeah, I would really like to start using an exoscope. So that's why I'm trying to find out which brands to invest in. So
yes, so the Samuel Institute in Japan already the abundant to use the microscope. So all cases treated by the exoscope. Of course, some resolution is a bit worse than the microscope, but it's enough, I think. Thanks so much.
I think you can ask the sales to have a try for yourself, and also with different brands.
Yeah, we have Storz endoscope which we use, but if a Storz has an exoscope as well, then I may want to try it actually.
Thank you. In the interest of time, I think we'll move ahead, and I'd like to invite the next speaker, Professor Kataoka, and he's going to talk on mechanisms of development of intracranial aneurysms.
Can you hear me?
Yes, we can hear you.
Hey, so thank you, Chairman. So I'll share my slide now. Oh, sorry, Anton. Okay, I'll share my slide. Can you see my slide correctly?
We can see your slide. Can you speak a little louder? We can hear you, but if you can increase the volume, it will be good.
So, and good evening, everybody. First of all, I appreciate Professor Kato inviting me to the webinar. I'm 𝘏𝘪𝘵𝘰𝘴𝘩𝘪 and belonging to National Cerebral and Cardiovascular Center, Osaka, Japan. I specialize in cerebrovascular surgery. So while treating many patients, I've been doing research work on intracranial aneurysm. So today I'd like to talk about mechanism of development of intracranial aneurysm. As you know well, subacute hemorrhage is the severest form of stroke. Many people die of SAH, and the major cause of SAH is ruptured intracranial aneurysm, accounting for 85% of all causes. In Japan, many intracranial aneurysms are detected in BrainDoc. BrainDoc is a unique system to Japan and medical checkup of brain for healthy people. Most intracranial aneurysm detected in BrainDoc is 3 milliliter or less in size. In general, aneurysm more than 5 millimeter is indicated for a surgical intervention. Of course, an aneurysm between 4 and 5 millimeter in size, it can be a candidate for surgical intervention for various reasons. For example, it is located on ACOM or PCOM, or it has a BREB, and so on. Supposing the half of the aneurysm between 4 to 5 millimeter in size is indicated for surgery, even for it, and 90% of intracranial aneurysm detected in BrainDoc should be observed without any surgical intervention. Do not need to be operated is not necessarily good for patients. These are data of quality of life measured by SF-36 for patients with unruptured aneurysm, patients with other diseases, and healthy people. Patients with unruptured aneurysm shows the score of vitality or score of vitality. Score of vitality of low emotional fall down after diagnosis. Patients with unruptured aneurysm suffer from anxiety and depression, maybe because they are afraid their aneurysm may rupture. So the prediction of natural history of each aneurysm patient is very important. We use phase risk scores in clinical setting. Phase risk score was made based on pooled analysis of 6 cohort studies: ISUIR, UK, Japan, SWAP, JK study, 𝑨𝑪𝑵𝑺 study, and 𝑨𝑪𝑵𝑺 study. And phases and its initial of population, hypertension, age, site, earlier stage, and site. And added scores after weighing each item indicates the 5-year risk of aneurysm rupture. But the phase score is not always useful in clinical practice. Here, I will show you the cases of ruptured aneurysm during follow-up in our institute. Most patients have some patients have high phase score, but most of them have low phase score, a low risk of rupture, less than 5% in 5 years. So, unmet medical needs for intracranial aneurysm at this moment is to develop the less invasive treatment like medical therapy, and to develop more precise prediction system for rupture. For this purpose, we have to understand more detailed mechanism of intracranial aneurysm. The essence of intracranial aneurysm does not lie in its shape, outward bulging, but in the degenerative change in vascular walls. Intracranial arteries lacks in external elastic lamina, but the internal. This is a specimen of ruptured aneurysm resected with parent artery. Intracranial arteries have the internal elastic lamina, and internal elastic lamina provides vessels with strength. But in aneurysm, an internal elastic lamina is lacking from the neck portion. Instead, the media becomes thicker than usual. That's the apex of dome, and the media also becomes thin, easy to rupture. The process leading to the growth and rupture of intracranial aneurysm is still poorly understood. Some genetic, environmental, and hemodynamic factor causes chronic inflammation. It results in degenerative change in the vascular walls and finally leading to growth and rupture. The only thing what is clear is chronic inflammation is a key event of the process of intracranial aneurysm formation. To disclose a detailed mechanism of inflammatory inflammation in vascular walls, we have used the experimentally induced intracranial aneurysm model. Professor Hashimoto, and he was a past professor in Kyoto University, established this model in 1978. In this model, aneurysm is induced by hemodynamic stress induced by occlusion of the contralateral CCA and hypertension by high salt diet and ligation of renal arteries. After these maneuvers, an circular aneurysm is induced at the arterial bifurcation of olfactory artery and anterior cerebral artery in rats. And this aneurysm quite resemble intracranial aneurysm in human pathologically. At first, using this model, we investigate the macrophage infiltration in aneurysm walls, because macrophage infiltration in human intracranial aneurysm had been reported. In a rat model also, macrophage infiltrating the vascular walls, and CD68 positive macrophage can be seen in the vascular aneurysm walls. And we reported these results to Stroke 2007. Next, we investigated why macrophage accumulate in the aneurysm wall. We took notice of NF-kappa B, and it is a potential transcription factor for an inflammatory reaction in vascular walls. NF-kappa B forms heterodimer and exists in cytoplasm in steady state. And after phosphorylation, NF-kappa B is activated and can move to the nucleus and bind to the DNA. And this is chemistry done by using antibody recognizing only phosphorylated and DNA binding form NF-kappa B. As you can see in these photographs, NF-kappa B is phosphorylated, activated in the early stage of aneurysm formation, and the mice deficient of P50 subunit of NF-kappa B, almost no aneurysm occurred. These results suggest the NF-kappa B activation is the key event for aneurysm formation. After these studies, we disclosed some inflammatory cascade in aneurysm walls one after another. Here is a schematic drawing of inflammatory cascade in aneurysm wall. Hemodynamic stress and inflammatory reaction activates NF-kappa B in endothelial cells, and it results in transcription of MCP1 and BCAM1. These promote the recruitment of monocytes in blood, and monocytes change into macrophage and infiltrated in the vascular walls. Also in macrophage, NF-κB is activated and promotes the production of MPP219. These proteins degrade the extracellular matrix in vascular walls, and macrophage also produce the reactive oxygen species and induce nitric oxide synthase and some inflammatory cytokine, and causing inflammation in vascular walls. After making clear that the inflammation is really important in vascular aneurysm formation, we start thinking some anti-inflammatory drugs have an inhibitory effect of aneurysm growth and rupture. We first tested the effect of statin. The statin is known to be a so-called pleiotropic effect and preventive effect for inflammatory reaction in vascular walls, independent of its cholesterol lowering effect. Administration of pitavastatin, kinds of statin, results in prevention of aneurysm growth and degenerative changes of vascular walls in rat model. Next, we tested the effect of DPP-4 inhibitor. DPP-4 inhibitor is a drug for diabetes and inhibits degradation of incretins. It has also protective effect on cardiovascular events independent of the incretin pathway like statins. So administration of DPP-4 inhibitor anagliptin have an inhibitory effect of growth of intracranial aneurysm. As you can see in this slide, and here is the luminal side of the aneurysm and aneurysm development and like this in the control group, and in anagliptin treated group, aneurysm size is smaller and the aneurysm wall is thicker than in the control groups. This is a chemistry for macrophage accumulation in aneurysm wall. Macrophage is expressed as red fluorescence in this slide. The number of macrophage accumulated in the vascular wall is smaller in anagliptin treated group. In addition of statin and DPP-4 inhibitor, many drugs are nominated as a candidate for preventive drug for intracranial aneurysm. Especially aspirin is famous because SH is infrequent in patients taking aspirin in ECS study. I believe I think many drugs, and I hope many drugs are developed for aneurysm prevention and used for clinical use. But the prevalence of intracranial aneurysm is very high, and I think it is unrealistic that all patients with unruptured aneurysm continue to take drugs every day for a long time. So next we took notice of the essential trace element of diet. So zinc. Zinc is the essential trace element in human, and needs for prenatal postnatal development, and works as a cofactor of many enzymes. Administration of zinc results in the suppression of aneurysm growth and degenerative change in vascular walls. As I mentioned before, NF-κB exists in cytoplasm binding with I-κB alpha. I-κB alpha prevents NF-κB from moving to the nucleus. Once the inflammatory stimuli added to the cell, IKK complex proliferated the I-κB alpha and resulting in the release of NF-κB, and NF-κB can move to the nucleus. A20 protein has zinc finger domain, and the zinc administration pronounced and potentiates the effect of A20. A20 inhibits IKK complex, so the zinc inhibits the IKK complex potentially pronounce the IKK complex and inhibits the NF-κB pathway. Required amount of zinc is more than 10 mg in Japan, and in contrast, average intake is 8 mg. So zinc deficiency is 30% of adults in Japan. And zinc deficiency, cause of zinc deficiencies are unbalanced diet, insufficient exercise, habitual drinking or smoking, and stress. Interestingly, most of them overlaps the risk factor for SAH. Process leading to the growth and rupture of intracranial aneurysm here and again. So I move to the hemodynamic factors effect to the chronic inflammation. This is a result of CFD and of the human MC aneurysm. CFD is a computer simulation of fluid dynamics, and CFD has been applied to intracranial aneurysm study with the development of computer performance since 2000. CFD study of intracranial aneurysm first published in 2004 by Dr. 𝘠𝘭𝑗ima in Tokyo University. In this paper, they insisted on low wall shear stress is related to the rupture. After that, many papers are published about comparing ruptured aneurysm and analyzing the risk factor for rupture. But some papers insist on the low wall shear stress is related to rupture, and the others insisted on high wall shear stress is related to rupture. And conflicting results are have been reported, and the conclusion has not yet to be decided. I think there are many reasons for this, and but we started to investigate the first step, how blood flow causes inflammation. For this purpose, we tried to perform CFD analysis in rat aneurysm. For CFD analysis, we have to obtain the shape of intracranial arteries in rat. After some trials and errors, we succeeded in getting the clear image of rat intracranial aneurysm by 7 Tesla MRI. In this process, we incidentally found the arterial bending progressed during the aneurysm formation. A left panel shows the preoperative status of intracranial artery in rat. After 1.5 months, the artery began to bend, and after 3 months, the arterial bending progressed further. Interestingly, the extent of arterial bending well correlated with aneurysm size. The PD angle means the angle between the proximal parent artery and distal branches. PD angle is related to aneurysm size. And the number of macrophages accumulating in the vascular wall is also well correlated with PD angle. These results suggest that arterial bending contributes to macrophage accumulation and leading to IA development. There is an intimal pad, congenital intimal pad at the arterial bifurcation between ON and ACN in rats. And intimal pad is a small buzzing of the luminal surface of the intracranial artery, and the aneurysm occurs always and just distal to the intimal pad. This small structure have a great influence on CFD analysis, so we use a model in which the intimal pad is added, And here is the result. In general, high wall shear stress is related to the aneurysm occurrence, but in the result, in this model, there are no high wall shear stress area around the aneurysm prospective site. At least, wall shear stress we cannot explain the occurrence of aneurysm by wall shear stress in this model. Hemodynamic stress and classified into wall shear stress and vascular wall stress. Wall shear stress is a tangential forces to the vessel surface and acting on endothelial cell directly. And vascular wall shear stress is circumferential forces against blood pressure and acting on area inside a vessel. And this is my hypothesis that the interpad exists circumferentially and restricts the movement of vascular walls. After inducing aneurysm, elevated blood pressure causes excessive vascular wall stress, and at the site near the interpad, circumferential movement restricted, so the longitudinal wall strain is increased and causing stretching forces to the vascular wall in this site. This is a live image of arterial bifurcation of ON and ACA in tight rat. Tight rat has fluorescence in the endothelial cells. From the video analysis in the lower panel, stretching force is, we found a stretching force at the arterial bifurcation between ON and ACA. In fact, an interpad exists in human, also in human intracranial aneurysm. This is a post-mortem pathological specimens and intracranial aneurysm in human, and you can see the small buzzing exists near the aneurysm neck. In the OA-ACA model, unfortunately I cannot depict the aneurysm itself because it is too small. So we tried to establish a new model to produce a larger aneurysm, cervical CC aneurysm. After end-to-side anastomosis rat cervical CCA, aneurysm rise near the anastomosis site. The size reaches more than 3 mm and can be depicted by 10 Tesla MRI. And the rat CC aneurysm resembles the human intracranial aneurysm. And for example, internal elastic lamina was disrupted and the media becomes thin in the apex of the aneurysm. They have a three-layer structure, and you can see, and it is not a pseudo-aneurysm. And the macrophages also infiltrate into the vascular wall in cervical CC aneurysm. Interestingly, the larger the aneurysm is, the number of macrophages accumulated is larger, and suggesting macrophage accumulation also contributes to the aneurysm growth in this model. One advantage of this model is that we can see which part of the aneurysm will grow in the future by taking MRI serially with animal alive. In this aneurysm, this portion will grow in the future, and this portion has high wall shear stress, low wall stress, and high OSI. By CFD analysis. OSI is the oscillatory shear index, and the direction means directional changes of wall shear stress during a cardiac cycle. Simply, high OSI means a complex flow. And next, we investigate the macrophage accumulation in the arterial walls by felmoxitol and iron oxide nanoparticle, Carboxyl is taken into macrophage and depicted in a low intensity in T2 star image. Here you can see the macrophage accumulated here and in the growth site of aneurysm. And this site has low wall stress and low wall shear stress and high OSI. In this slide, I summarize what we know now. And hemodynamic stress causes the morphological change apparent artery, which result in macrophage accumulation in the vascular wall. At the same time, hemodynamic stress provides stretching forces to the artery and causes early change of aneurysm formation. And later, another hemodynamic stress, including low wall shear stress and complex flow, further promotes the macrophage accumulation of the vascular wall. Accumulated macrophage promotes inflammation and degenerative change in vascular walls. In summary, this mechanobiological complex is really important in intracranial aneurysm development. Based on this knowledge, I think the future direction of intracranial aneurysm treatment like this. The most important is prediction of natural history in each patient. After stratifying risk factors, for high-risk group patients, of course, and they need surgical interventions. For medium-risk group patients, developing a drug is a promising strategy, I think. For this purpose, we have to develop a drug for preventing aneurysm growth and rupture. And for low-risk group patients, I think lifestyle improvement, for example, prohibiting smoking or blood pressure control, is enough for this low-risk group patient. And for example, a zinc supplementation would be promising if the effect of zinc and would be demonstrated in human intracranial aneurysm. Today, I talked the mechanism of development intracranial aneurysm and mainly from our research works. And I wish today's talk would be helpful for you understand the aneurysm biology. And thank you very much for your attention.
Thank you very much, Professor Kataoka, and a very, very interesting basic lecture on the pathophysiology of aneurysms and how in the future maybe we can, predict the rupture and prevent the rupture. So I would like to ask you a question. Do you regularly give aspirin or zinc to your patients, or?
Not yet.
Not. Okay.
And so first, we have to demonstrate the effect of zinc for human intracranial aneurysm.
Okay.
So we start the etiological study now.
Okay. Thank you. Dr. Sukirti, do you have any comments or questions?
I was interested in that brain scan. You had told that you screen the patients regularly in Japan. So what is the screening procedure basically?
And usually we perform an MRI and an MRA for healthy patients who hope the screening. For
at what age?
What age?
Age. Yeah. At what age?
Any age.
Any age. A youngster can just walk in and get a scan.
If they wish to be if they wish the screening for brain disease.
So basically, it's a voluntary thing by the patient if they want to get scanned.
And we explain to the patient the result of MRI study. And so, what is this your question?
No, it's like it's a patient's choice that
yes.
I want to get a scan.
Of course.
Okay. Thank you.
Dr. Daniel, can you unmute yourself, please? I don't know if he's there. Dr. Farhad?
Yes, Professor, thank you. It was a wonderful molecular level and inflammatory pathophysiology session. I have a question regarding the CFD to Professor regarding his presentation. That is, can CFD be taken in the follow-up of aneurysm treatment as a predictor of aneurysm wall remodeling or treatment success? Can CFD be incorporated in the follow-up protocol? Can we include it?
Your question is about the CFD after the creeping surgery, no?
Yes, sir. Yes. After surgery
Uh,
or
um,
endovascular treatment.
I'm not sure on whether this result of CFD and improves the outcome of creeping surgery and vascular surgery, and so I believe the CFD and can predict the natural history of intracranial aneurysm in some way, but I'm not sure whether it helps the prediction of outcome after treatment.
Okay, thank you.
Thank you, Professor.
Dr. Daniel, you have to say something?
Yes, hi everyone. Dr. Kataoka. Yes, my question is, do you use DPP4 inhibitor in the median risk patients, or do you use after the postoperatory patients? You can use in the median risk patients. DPP4 inhibitor.
Can you repeat your question? It's not very clear.
Yes, he used the DPP4 inhibitor in patients, in the medium risk patients, drugs, DPP4 inhibitors.
He's not using drugs now. He's not yet. They are looking at the trials. They're not yet using the drugs.
Drugs.
No, because he mentioned like it can use in the medium risk patients.
But they're
we use the drugs and in a rat experiment model, not for human.
Professor Kato, would you like to make some comment?
片岡先生、ありがとうございました。The excellent talk. Thank you very much. Just I want to ask because some the aneurysm wall infectious remodeling is some related with the MR enhancement, the wall enhancement.
Yeah. I also interested in the aneurysm enhancement, but I don't know and what is the essence of enhancement. So we cannot see the gathering in aneurysm tissue. So I'm not sure what is the what that mean. What the enhancement means.
So one more question is just the aneurysm wall sometimes very yellow. That means a very scotic change. So maybe sometimes even the large aneurysm, maybe from your strategies, sometimes we do not need to treat. How do you think?
I agree with your opinion, and during operation we sometimes see the annular wall is very thick and all around. So, but I don't now we don't know which aneurysm and should not be operated or not, and so the size is one measure for one clue to for it, and now I'm not sure which aneurysm can be and should be operated before operation. I don't know why.
Okay, thanks so much. So what an excellent picture. Thank you so much, Kataoka sensei.
Thank you for your Kato, Professor Kataoka. Let's move on to the next lecture, and I'd like to invite Dr. Abhinash for his lecture on management of C1 segment aneurysms.
Thank you, Dr. Abida. Am I audible to everyone?
Yes, you're audible. You can share your screen now.
Yeah, shared. So my screen is visible now?
Yes.
Okay. Good evening, everyone.
Make it full. Yeah, okay. Okay.
Is it okay now? Yeah. Good evening, everyone. I am Dr. Avinash Datta. I am currently working as an associate consultant in the Department of Neurosurgery, Sakra World Hospital in Bangalore. I would like to thank Professor Yoko Kato Sensei for giving me this opportunity to speak on this platform. I am a former fellow in cerebrovascular surgery under her in Ujita Health University. So today I would like to present our experience as an institute in the management of extracranial carotid artery aneurysm. So to start with the review of literature, it is per se a very rare entity, constituting only 1% of all, less than 1% of all aneurysms. De Jong et al. Had defined it as a diameter of the carotid bulb 1.5 times that of the common carotid artery. The most common locations of the extracranial aneurysms are the common carotid artery near the bifurcation, followed by mid to distal internal carotid artery. So the causes, like any other aneurysm, the commonest is atherosclerosis, followed by trauma and infection. Also the pseudoaneurysms following carotid endarterectomy and connective tissue disorders.
Doctor, sorry to interrupt, but there is a continuous beeping sound. Is there any instrument on near your...
I'm sorry about that.
Is there a kind of
yes.
echo, I think?
Yeah. Let me just try and fix it. Okay. I'm sorry about that. My apologies.
It's still there, but okay.
Okay. Across literature, the natural course of cranial carotid artery aneurysms is still not clearly understood. All we come across is case reports, and there has been no big series on this entity per se. So hence no treatment guideline or expert consensus for the management of this condition has been developed yet. So coming to the clinical presentations, of course, in countries like Japan and other developed nations, they can show up on screening as asymptomatic entities. Otherwise, symptomatic ones include a mass in the neck or neurological conditions like transient ischemic attacks or strokes, then lower cranial nerve symptoms, Horner syndrome, and so on. So the symptomatic cases always carry a higher morbidity and mortality, and so they are the ones which warrant urgent intervention. So in our series, I will present a total of 9 cases spanning over a period of 10 years from 2013 till date. 4 of these aneurysms are true aneurysms, 3 are pseudoaneurysms, and 2 are dissecting aneurysms. So to start with case 1, this is a case of a true aneurysm, 62-year-old female who presented with transient ischemic attack. CT angio revealed a small 0.5 centimeter saccular aneurysm originating from the internal carotid artery just distal to the carotid bifurcation. That one. So she was managed conservatively with dual antiplatelet therapy, and she has been on regular follow-up and has been doing well. Now going to the second case, this is a 41-year-old male who presented with sudden right hemiparesis with slurring of speech. MRI was done for him, which showed this left MCS stroke. Whereas when the CT angio was done, an aneurysm was seen in the extracranial ICA. So the DSA was done, and he was planned for endovascular intervention in the form of a covered stent. This is the scan shoot following the deployment of the stent. The stent we used is a Fluency Plus stent graft. So coming to the next case, case 3, this is a lady, 78-year-old female, who is a known case of CA esophagus. She presented with hematemesis. So after a lot of evaluation, finally DSA was done, and it revealed a pseudoaneurysm involving the right CCA. Again, she was also planned for endovascular intervention. So again, we used a covered stent. And you can see post deployment, the esophageal stent and the fluency plus stent graft. So the fourth case is there of a traumatic pseudoaneurysm, a 30-year-old female who presented with screwdriver injury to the neck, followed by severe pain and local swelling on the right side of neck. So USG Doppler was done, which revealed a pulsatile swelling arising from the right common carotid artery. DSA was done, which revealed a pseudoaneurysm in the mid to distal common carotid artery. So that is the aneurysm. And this is quite proximal in the neck. So for her also intervention was planned. This is again the same stent was used. This is post deployment, and that's the covered stent. As we can see, in all the cases immediately post deployment, there is complete exclusion of the aneurysm from the circulation. The same stent was used in this case as well. So this is case number 5, a traumatic pseudoaneurysm, a 17-year-old male who presented with sudden right hemiparesis in 20 days with facial numbness. He got into a fight and with knife injury over the angle of left mandible 3 months ago. In his case, the CT angio revealed this pseudoaneurysm in the ICA, distal to the bifurcation. For him, again, we planned a covered stent. This time we used a papyrus covered stent, and like all other cases, this is the post-deployment shoot. So this is the papyrus stent by Biotronic that we use for this case. Now this case is number 6, a dissecting aneurysm, 53-year-old male who again presented with right hemiparesis and dysphagia. So this is the DSA run. The diagnostic run shows a long, quite a long segment of dissection. So this is the dissection and with a pseudoaneurysm. So this entire length was around 3.5 centimeters. So we deployed 2 stents of 3 centimeter each across this. So this is the post stenting angiogram. Here we used Resolute Onyx stent by Medtronic. So in the endovascular cases, we have used in all of them across all the aneurysms, whichever we have managed endovascularly, we have used coronary stents. There are no dedicated neuroendovascular covered stents. So in all the cases, we have used coronary stents. So these, coming to case 7, this was a 68-year-old female who presented with trismus and syncope on mouth opening. So CT angio was done for her, which revealed a right C1 segment giant aneurysm. This is the DSA image, which shows the giant aneurysm. The plan for her was parent artery occlusion in the form of right carotid ligation and ECIC bypass with a saphenous vein interposition graft. So this is the follow-up angio showing a functional graft with good distal flow. This lady is also doing well on follow-up. Then coming to case number 8, this is a true aneurysm. 77-year-old male who presented with left hemiparesis and dysphagia for 10 days. This was again a big giant aneurysm involving the extracranial ICA. Here there was quite a redundant loop of ICA. So we didn't think of parent artery occlusion with bypass. Instead, excision with end-to-end anastomosis was done. So here we can see the aneurysm and the loop. This is the most recent case which we did this year. A 35-year-old female who was being followed up conservatively in Sri Lanka for almost 1.5 years. She had a swelling in the left neck which gradually increased in size with Horner syndrome. So the E1 segment from the scan she brought to us, it revealed a giant aneurysm of 6.7 into 5.9 into 4.5 centimeters. So that is the swelling, and this is the DSA run, which shows a giant aneurysm with quite a redundant loop of ICA. So in her case, like all other of our other endovascular interventions, we had planned a covered stent. But when we went ahead and tried to negotiate the guide wire across the neck of the aneurysm to deploy the stent, we were unable to do so. So we had to again go back and then plan for a parent vessel occlusion. So that was planned for the next day. We counseled her and we did this right ICA contrast run while compressing the left common carotids, and there was good cross flow across the ACOM and the PCOM. So we went ahead and did this parent vessel occlusion with the 𝘂𝑪𝑵 vascular plug, 6 mm into 6 mm size with a few coils. So this is the post-intervention angiogram showing complete occlusion of the ICA. This lady in the post-op period did have transient right hemiparesis with little bit of slurring of speech, but she recovered within a period of a week and got discharged. She's doing well on follow-up. So now coming to the discussion part. So decision making in the management of these kind of aneurysms, like most other aneurysms, there are patient-related factors and pathology-related factors. In patient-related factors, age, of course, the younger the age, the more aggressive we can be. So intervention is more supported in the younger age, whereas observation can be earmarked for the more advanced age group. Vascular anatomy, again, the very much tortuous vessels or a difficult arch can preclude endovascular intervention, whereas a high bifurcation in the neck can make neck dissection very difficult and make open surgery difficult. So comorbidities, again, we have to take into consideration. And mode of presentation, of course, it can either be an emergency presentation or elective, like screening kind of presentation. Pathology-related factors, of course, the size, the very small size aneurysms can be observed and followed up sequentially. The location, again, that depends on the parent vessel. If it is very high up, crossing the mandible, then open surgery becomes difficult and endovascular takes the upper hand. Etiology, again, across all the other modes, the common ones are even following carotid endarterectomy, pseudoaneurysms, infection, and all that. So endovascular has been emerging as a mode of treatment based on the pathology. Now, conservative management, which are the cases we can manage conservatively? Like I already said, asymptomatic or incidental ones can be managed conservatively. This applies more in case of the already developed nations where they have screening. Then the old patients with multiple comorbidities and smaller size of the aneurysm. So conservative actually means that we put them on statins, dual antiplatelet, aspirin and clopidogrel, and antihypertensive. So open surgical cases, this is a schematic diagram showing the excision with an interposition graft, excision and end-to-end anastomosis, and excision and patch angioplasty. So the techniques are those, and carotid ligation should be the last resort. So what are the indications for open surgery? Actually, open surgery is still the gold standard in the management of these conditions. So in younger patients, open surgery has a better result than unfavorable carotid anatomy for intervention, like long redundant loop of an ICA. Then greater aneurysm size. This indication, of course, is becoming more and more less because endovascular is slowly taking over. And carotid bifurcation, not too high. If it is quite low in the neck, then open surgery is more amenable. So these are the three zones of the carotid bifurcation from 1, 2, and 3. Zone 1 is very much amenable to surgery, whereas 2 and 3 being higher bifurcation, surgery and dissection becomes difficult. So intervention can be planned. So what are the complications and disadvantages? There is always a risk of cranial nerve injury, especially in high bifurcations of the carotid. Mostly the hypoglossal nerve and the other spinal accessory, and even sometimes the recurrent laryngeal might get injured. So just like I said, it is difficult for high bifurcations, and it is definitely not recommended on already operated or irradiated necks. Now, endovascular, 6 of our cases we manage endovascularly. Indications, whatever are the contraindications for open surgery are the indications for endovascular, like old age with comorbidities precluding open surgery, then high bifurcation aneurysms, and previously operated or irradiated necks. So the options, the one that we have used most is the covered stent, then bare metal stent with or without coiling, flow diversion, stent assisted coiling, and parent vessel occlusion. Out of these, covered stent and parent vessel occlusion are the modalities that we have chosen till now. So the issue always with endovascular is that of progressive recanalization and delayed aneurysm rupture. There might be early thrombosis of the stent itself leading to late stenosis or occlusion. And moreover, whenever you deploy a stent, we have to put the patient on dual antiplatelet therapy. So that is also not a very desirable scenario, especially for younger patients. So covered stent, the advantage is that it has an immediate action with immediate occlusion and immediate exclusion of the aneurysm from the circulation. The risk of thromboembolism is much less compared to a bare metal stent, and it is best for non-branching parent arteries. Only issue is that it is more rigid and not as flexible as a bare metal stent. So to conclude, this is definitely a rare entity with a very limited material across literature. Mostly we come across case reports. So the goal is to prevent the thromboembolic complications. Management, be it conservative, surgical, or interventional, must be tailored to each individual, case by case, and timely and precise management can definitely have a significant impact on outcome. Thank you so much for your patient listening. And I'd like to mention that all these cases have been done by my mentor, Dr. Swarup Gopal, and he's the Director of Neurosciences in our institute and takes care of the neurovascular wing. So it is his work that I'm presenting. I have assisted him in all these cases. Thank you so much.
Thank you, Avinash. That was a very interesting talk and a very rare lesion. Actually, I have seen only 2 in my entire, and one of them was so large that it actually, while waiting for the procedure, it ruptured. So, of course, you have to treat them as soon as you recognize them. I'll invite a short comment from Professor Kato, and then we'll move ahead.
Thank you very much, Avinash. Because it's time to learn how to apply the endovascular treatment. So maybe you can discuss with Kataoka Sensei how fast, how soon you need a treatment, either endovascular or open surgery. It is very interesting. Thank you so much. It's really
thank you, Sensei. Thank you so much.
Summarize. Congratulations.
Thank you so much.
Thank you, Professor Kato. Thank you, Avinash. So moving on, going to the next lecture, I'd like to invite Professor Miyake, and he's going to talk of technological advances in management of glioblastomas.
Okay, thank you, Chairman. So I prepared Oh, can you?
Yes, Abhinash, can you unshare your screen?
Yeah, just a second. Done.
Okay. Okay, Professor Miyake.
Okay. I prepared my slide. Can you see my slide? No?
I can see your slide. Put them in a slideshow. Yes.
Okay.
Yes, okay.
So I'll start my presentation. I'd like to thank for having given me a chance to discuss the management of intraoperative technology advances, intraoperative MRI, neuronavigation system using PET, and 5-aminolevuric acid-induced fluorescence image-guided surgery for glioblastomas. I have no COI. Okay, so we will discuss the diagnosis and treatment of gliomas. As we know, glioma is one of the CNS tumors with a very poor prognosis, which we must overcome. So, one of the reasons why gliomas are so difficult to diagnose and treat is that they invade areas that cannot be detected by MRI. Just fungus invaded food from one end to the other without you know it. Another reason is that the glioma evolves through the complex series of branch processes called branched evolution, rather than the relatively simple linear evolutions. Here we have some difficult questions. What do you expect to evaluate image for CNS tumors? Can you actually diagnose and differentiate between CNS tumor, perform histopathological diagnosis, or perform molecular diagnosis such as genetic diagnosis, or determine the malignancy of tumors, or estimate the prognosis? When we perform a tumor biopsy or removal, where should we biopsy? Where to start and how to approach the tumor to minimize risk and maximize removal? How much of the tumor can be removed? Follow-up after initial treatment, tumor removal or chemotherapy or radiotherapy. Is the tumor growth under control? Has the tumor recurred? Is this a tumor pseudoproliferation or radiation necrosis? They are very difficult questions and cannot be solved quickly. Meanwhile, considering the response to treatment and prognosis of glioblastoma, these predictors are age, a value of extent of resection or a degree of tumor residual value, performance status before treatment, presence MGMT promoter maturation, and the presence of a NAT IDH mutation. What we can do to prolong survival is to increase the tumor extraction rate and minimize the tumor residual volume. For these purposes, MRI is used as an indicator during the removal of glioblastoma. This paper is very famous from UCSF. For patients with newly diagnosed glioblastomas, aggressive value of extent of resection equals to improvement in overall survival, even at the highest level of resection. Interestingly, subtotal resection as low as 78% also corresponds to survival benefit. The other paper shows that supratotal resection has been proposed to determine the extent to which the high-intensity area of T2 flare should be removed. According to this JNS paper, this Kaplan-Meier curve shows that removal of more than 50% of the flare high-intensity lesions resulted in prolonged overall survival. As for the prognosis of glioblastoma, this paper indicates that removing tumor residual down to less than 5 milliliters using enhanced MRI resulting in an improved prognosis. To reduce the tumor residual volume, we usually use an intraoperative MRI. This paper shows the intraoperative MRI reduced the tumor residual volume and prolonged progression-free survival to 7.5 months. So we showed illustrative cases. first preoperative FLAIR high-intensity area was identified and marked. So tumor removal was then performed based on these markers. However, the initial intraoperative MRI revealed a residual FLAIR high-intensity area deep within the respective resection cavities. So a marker was placed in this region, and tumor excision was carried out accordingly. In the second intraoperative MRI, the target tumor was successfully removed. So intraoperative MRI is very useful in understanding tumor residue. In addition, we believe the fluorescence-guided resection with 5-LA surgical removal is very effective. Tumor tissue was detected in all of samples with strong fluorescence, and in 94% with vague fluorescence. This paper shows that 5-LA guided resection has result in improved progression-free survival. Our data show a tendency to prolong overall survival by removing the tumor until no fluorescence was seen under 5-LA guided resection. However, it is important to know that 62.4% of tumor cells are still present in the non-fluorescence area. So we need to decide a new and next intraoperative target that was neither MRI nor 5-AL. So what is the next target? MRI also provides metabolic evaluation such as DWI, ASL, MRS. But it is difficult to determine the correct diagnosis based on these MRI findings. So, positron emission tomography, PET, using radio tracer for molecular and metabolic imaging, and we expect improvement the diagnosis of CNS tumors. So I talk about a diagnosis and grading based on PET studies for CNS tumors. In our institute, we can use two PET tracer PET scanners for a diagnosis CNS tumors. This table shows isotope and PET tracers. In the world, many types of PET tracers are used for diagnosing brain tumors. In our institute, we usually use 5 PET tracers for diagnosing CNS tumors. So I'll explain the PET tracers. So FDG is a glucose analog PET tracers, and in the most frequently used radio tracer in Japan. The metabolism of FDG is related to glucose transporter and hexokinase activities. A second type of methionine amino acid tracers. We usually use methionine PET tracers. So I explain methionine PET tracers. In gliomas, amino acid transporter such as system L and protein synthase have been enhanced. System L consists RAT1 and 442HC. The accumulation of methionine is related system L expression. Third type of PET tracer is a nucleic acid tracers. Malignant tumors are characterized by increased cell proliferation and DNA replication. FLT tracer can be used to image cell proliferation, since FLT metabolism is related to thymidine kinase activity. The fourth PET tracer is utilized to detect hypoxia region within tumors. Tumor hypoxia occurs due to rapid tumor growth and result in the adequate blood supply. This condition leads to significantly lower oxygen level compared to normal tissue. So we employed fluoromethanol PET tracers for hypoxic imaging. For example, in necrotic environment and normal tissue environment, nitroreductase remains inactive. So fluoromethanol returns to the vascular lesions. In contrast, hypoxia environment, nitroreductase become active, so leading to metabolism and entry of fluoromethanol in hypoxic cells. Our study demonstrates that oligodendroglioma WHO grade 2 and 3 tend to have higher accumulation of methionine despite a lower WHO grading than glioblastomas. We have to carefully consider the evaluation of glioma grading using only methionine accumulation. Based on the above, we can diagnose and classify gliomas using PET scans according to WHO 2021 criteria. Let's return to the main theme of this presentation. What target can enhance glioblastoma removal rate? We believe that targeting the accumulation of the on PET scans is a visible option. This is because, as demonstrated in this paper, reducing the FET PET accumulation to less than 1 milliliter has been associated with an extension in overall survival. So I'll show the first illustrative cases. This case was glioblastoma identified in male patient in his 70s, located left frontal lobe. So methionine tumor to normal ratio is 6.45, and FLT tumor to normal ratio is 36.84. Both indicating significant elevated values. So I show operative videos. So green line indicate enhanced MRI. Red line represent area is with methionine uptake, and blue line is a vein. To mark the tumor boundaries, fence posts are inserted. While following the course of the vessels, colposcopy is performed. So tumor is dissected using QSAR clarity. So diagnose this lesion a portion of the tissue is excised and submit of the intraoperative frozen section. This result confirms diagnosed glioblastomas. This result can be reviewed on the large monitor in the operative room. Additionally, discussion with the diagnosing pathologist can occur during the surgery. Future clarity allows the preservation of feeders in the detecting tumors. Ultimately, feeders are coagulated and cut, preserved in the several surface vein as a single pieces excised. The resection performed within the area covered the target methionine accumulations. And of course, 5-LA does not show fluorescence in this case. So next, I show the second illustrative cases. This case was glioblastoma identified in male in his 60s, located in the left temporal lobe. So methionine TNR is 4.07, FLT tumor to normal ratio is 15.58, and fluoromethanidazole tumor to blood ratio is 1.85. Accumulation of 3 PET tracers are high, allowing us to diagnose glioblastoma through PET image. I'll show the operative videos. After general anesthesia, the patient is placed in a supine position with the head rotated 80 degrees to the right. The skin incision is made to allow for large front temporal craniotomy, and the craniotomy is performed. Dura mater is also incised in a semicircular. As the region is localized in the sensory language area, language mapping is conducted under awake conditions. The examiner asks, "What is this?" The patient replies, "These are toothbrush." The examiner shows Japanese kanji characters and asks the patient to read this aloud. So, wait. The patient replies, "trains." So, stimulation of the region did not result in any language deficit, so the excision was initiated. Okay. So, initially we examined the fluorescence using 5-LA, but no fluorescence was observed. While referring to tumor area navigation, colchicotomy was performed and dissection of tumor border proceeded. Using QSAR clarity at power 20%, suction 20%, and tissue selection 2, suction and dissection were performed. So bleeding was observed from the vessel around the tumors. So when set to the tissue selection 4, there was no bleeding from vessel around the tumor during the suction, and only the tumor tips was suctioned while preserving the pure matter. So finally, the vessel to tumor were coagulated. And the tumor was excised. To remove the tumors. So no fluorescence was observed on the resection cavity with fiber. After excision, druggen was placed on the brain surface to prevent adhesions. Following dural suturing, the bone flap was replacement. The skin was sutured, and the surgery was concluded. Our data show this Kaplan-Meier curve presents the result of progression-free survivals and overall survival. When targeting the excision of enhanced MRI and methionine, excision the remaining volume of enhanced MRI to less than 1 milliliter has extended both progression-free survival and overall survival. Furthermore, excision in remaining volume of methionine to less than 1 milliliter has resulted in longer extension of progression-free survival and overall survivals compared to reducing the remaining volume of enhanced MRI less than 1 milliliter. Next, I show the third illustrative cases. This case was glioblastoma identified in male patient in his 50s, located in the right parietal lobe. The methionine tumor to normal ratio is 7.25. FLT tumor to normal ratio is 31.64. Chlormethanazole tumor to blood ratio is 3.69. In this case, we conducted an evaluation using novel PET tracers called THK5351. The accumulation of all tracers high, allowing us to diagnose glioblastoma through PET imaging. So I show the operative videos. The yellow line represents the area with new tracer called THK5351 update. To mark tumor boundaries, pen spots were inserted. So first, when I examine the presence of fluorescence from 5 areas, we observe the region emitted strong fluorescence. By following the course of the vessels, colchicotomy was performed. The tumor was dissected using 𝘂𝑪𝑵𝑘𝑠. 𝘂𝑪𝑵𝑘𝑠 allows for preservation of feeder while detecting tumors. We coagulate and cut the feeder repeatedly, ultimately excising the tumor as a single mass. When examining the presence of 5-area fluorescence, we observed faintly fluorescence area in the neck resection cavities. The area of faintly fluorescence with 5-area fluorescence as also within the accumulation range THK5351 when tissue was submitted in intraoperative frozen section in exhibited histology glioblastoma. Furthermore, additional excision was performed using 𝑞-circularity. The resection is performed within the area covered the target methionine and THK5351 accumulation. So we explained the THK5351. So THK5351 was developed as a probe capably recognizing tau proteins. THK5351 exhibits a high affinity for monoamine oxidase B, 𝑀AO-B. Notably, there is a high accumulation concentration of 𝑀AO-B in astrocyte associated with gliosis. Consequently, THK5351 accumulates in astrocyte involved in gliosis. Furthermore, THK5351 accumulated in both gliomas and the surround area affected by gliosis. So, tau protein is primarily an intracellular structural component. It raises a question of whether regions with increased tau protein levels might be implicated in cellular invasion. So our data shows that this Kaplan-Meier curve presents the result of progression-free survival and overall survivals when targeting the excision of THK5351. Excision the remaining volume of THK5351 to less than 1 milliliter has extended both progression-free survival and overall survivals. Furthermore, these results show that excision the remaining volume of THK5351 to less than 1 milliliter has resulted in a longer extension of progression survival and overall survival compared to reducing the remaining volume of methionine to less than 1 milliliters. In conclusion, I would like to again emphasize the importance of evaluating the morphological image such as MRI in combination with the molecular and metabolic image such as PET for the accurate diagnosis, treatment planning, and prognosis prediction of gliomas. Thank you for your attention.
Thank you, Professor Miyake. That was a very interesting lecture. I have a question. Do you use intraoperative ultrasound during the surgery? Ultrasound, sonography, intraoperative ultrasound. Do you use during the surgery?
Yeah, yes.
Okay. I'd like to invite Professor Gao for his comments or questions. Professor Guo. Is he here? Okay. Dr. Sukriti, you would like any question? Unmute.
Yeah. Nothing. I was just remembering the time when ALA was started long time back. So the cost factor was a major issue that time, maybe around 10, 15 years back. And it still is a major issue. So there are a lot of people who operate using the regular fluorescein. So what is your experience fluorescein compared to ALA? Fluorescein, regular fluorescein, which you use in eye surgeries.
I usually use usually use 5-area for the all patient or glioma patient. Is it okay?
No, my question is, when you use fluorescein dye, not the ALA dye, the fluorescein dye, it spreads more. And what is your experience compare of fluorescein with ALA, 5-ALA dye, the pink dye and the yellow dye?
Yellow dye?
Yellow dye, yeah. Fluorescent green yellow dye.
I didn't use a green dye.
Never.
So only a 5-area.
Okay.
Only I use
What about your
5LA.
experience, Dr. Abida?
Oh, I have just used it a couple of times, fluorescein. I don't use 5LA. Now I don't use any dye now. So, but fluorescein kind of gives the color appreciation is better with 5LA than fluorescein, I think.
But does not fluorescein go to the normal tissue more than the tumor tissue?
Looks like, yeah. I've used it only a couple of times, and I'll tell you the truth, actually the whole patient became yellow and the tumor didn't. So I just
Okay.
stopped using it.
Thank you.
I had the same experience like Abida, that I tried the fluorescein and everything just became yellow. So I also abandoned it. And I also don't use any dye because 5LA is very expensive to use it in Pakistan. So same experience like yours, Abida.
Yeah, Leela. I was really surprised. Except the tumor, everything was yellow. So
yeah.
Okay, Dr. Lin.
Yeah, thank you so much for that lecture, Professor Miyake. We have seen the latest studies with the excision of the flare on T2, increasing overall survival of our patients. So this is more on the overall survival. What about the functional survival of these patients? I mean, not just the overall survival, but more on functions, because sometimes we excite a large amount of the brain, which can involve actually some eloquent areas. So are there studies, discussing this possible problems?
Yes. So, it's that good point. So, flare area consists of tumor regions and edema regions. So, but I didn't know how to resect and place a tumor region in the flare T2 high intensity area. So we detect methionine and THK5351 uptake region is presence of tumor region. So we remove a target to uptake methionine and THK5351 uptake region. Okay.
Yeah. What about tumors that can be already over the motor strip? So what about if you are about to excise this, which do you prioritize, the possible function of the patient versus overall survival? How do you decide on that?
So it means include eloquent area in the flare T2 high intensity area. So we use bevacizumab. Do you know bevacizumab? VG. So we use a bevacizumab therapy. After the bevacizumab therapy, so reduce the high intensity area, reduce the flare high intensity areas. So initial patient is could not have a language function, but after the bevacizumab therapies, this patient recovered language and eloquent language function and motor function. So I checked the methionine area and THK5351 areas. So and I removed these areas and so this what you say remains the eloquent area functions.
Thank you, Dr. Miyake. Anyone else has any question? Any young neurosurgeon wants to ask a question?
I hope I'm young, so I want to ask one more question. Professor, when you are operating, do you send the border of the tumor for squash reporting, histopathology reporting during the time of the surgery?
Surgeon.
When you are operating the tumor, do you send the piece of tumor for histopathology reporting, called squash reporting or frozen section?
So first time today I show the operating videos. So so I first so dissection the
I think he didn't understand.
Yes. So how to say so?
He showed it. Sukriti.
Yes. First time I remove the frozen section
So my thing is, do you send it from the
after that? So yes.
So you send it from the doubtful part or the center part? That is my question basically.
Yes. So
where you have a doubt or the confirmed part?
I detect the area, no 5 area fluorescence areas, and outside of enhanced MRI, and in the within the methionine uptake area and THK5351 uptake areas. So I remove the biopsy, and the other part. So I remove the frozen section in no methionine uptake areas and only THK5351 uptake areas.
Okay. Thank you, sir.
Dr. Takashi, would you want to make any comment?
Thank you. Thank you, Dr. Miyake, for that lecture. So I'm Dr. Ko from Showa University, Tokyo, Japan. And as I understand, I know a lot about your papers and review the papers. So 5 area negative parts, so it's difficult to remove totally, but your data from PET is very very accurate for the total removal of tumors available. So unfortunately, in my institute, PET is not available. So so I review your paper and learn more. Thank you for nice lecture.
Thank you very much.
Thank you, Dr. Takashi. So I'd like to invite Professor Kato for her final comment.
Before that, I'd like to say thank you very much, Miyake Sensei. So it's very precise the report. Just I want to ask that usually how long does it take to remove the whole tumor under the ABEC surgery? Average.
Only one hour. To check the ABEC surgery, 1 hour.
1 hour extra.
Yes.
Okay. Thank you so much. So it's a time to close now. I think thank you very much for all 6 speakers. So I think the variety topics make I think so through to some inspiration from those the lectures, I think. But anyway, the basic anatomy and also pathology and also the image analysis is very important for young neurosurgeons. But in the future, I think the minimally invasive treatment is mainstream, I think. So of course, the endovascular endoscope, and also so many new devices and techniques. Hopefully you can learn a lot. Anyway, we learned a lot from those the experts lectures. I think you should have a very nice Christmas and holiday seasons. Actually, we don't have a Christmas time, maybe in Japan, I think. So thank you very much for this year, the whole year, dedication to the YNS WIN webinar. Thank you very much.
Thank you, Professor Kato.
Thank you, Professor Kato.
Hi.
Merry Christmas to all.
Yes, thank you, Aline. Congratulations on your your job.
Thank you, Professor Kato. Thank you so
yes,
much.
yes.
I invite you to come to Dubai.
Yes,
We
yes,
have an
yes,
Emirates title meeting in February. Yes.
Yes. Miyake Sensei, so let's go to Dubai together.
Yeah, thank you very much. Yes.
So you should
Nice,
invite Miyake Sensei.
a good experience
Yes.
for a good webinar. Yes.
Yeah, yes. Miyake Sensei is one of the top leading professor of the glioma in Japan. So I trust him very much.
Thank you very much.
Thank you so much.
So thank you, everybody, all the speakers and the panelists and the discussions for joining the session. And it was a very interesting session. And I hope to see you soon in the next webinar. And Merry Christmas and Happy New Year to everybody. Thank you, Professor Kato.
Thank you so much. Merry
Thank
Christmas.
you, Avinash.
Thank you.
Merry Christmas. Thank you so much.
See you again.